Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. Our topic this week, Policystic Ovarian Syndrome. What is it, and how to properly keep ovarian health in balance? Our guest is OBGYN Angela Parise. First, some background. Dr. Parise is a fellow in the American College of Obstetrics and Gynecology. She received her medical degree from the State University on New York in Brooklyn. She did her residency at Ochsner here in New Orleans, and after practicing in Mobile, she's back in the Crescent City. And it is our pleasure to welcome Dr. Angela Parise to Hello Health. Good to have you with us on the program.
Hi.
Yeah.
Nice to see you, Tom.
Same
Thanks for
here.
having me here.
You're very welcome. So how did you first get interested in medicine, and how did you end up in the field of OBGYN?
Well, I was actually 13 years old, and my grandmother was dying of breast cancer. And it was one of those times when you feel helpless and you feel like you need to make a difference. And I vowed when I watched my grandmother die that one day I would make a difference, and I was going to help with women's health, and somehow here I am today.
And grandmother looking down and watching, and I'm sure very appreciative of the work you're doing. So thank you.
Thank you. Amen.
What is polycystic ovarian syndrome, and how does someone know if they have it?
All right, so polycystic ovarian syndrome is a hormonal disorder, and it's generally among women of reproductive age. They come to me generally with infrequent or irregular cycles. They tend to have excessive male hormones or androgens, such as testosterone or other steroid hormones. And what you start to notice with these women are their ovaries start to look a bit abnormal. They start to produce many cysts, small collections of fluid, so we call it polycystic ovarian syndrome.
How common is PCOS?
So PCOS, we find it to be 1 in 10 women, or even up to 2 in 10 women in this area have been diagnosed with PCOS. We still find there are many more women out there who are not diagnosed with PCOS, even up to 50%. So if you think about that, that's millions of women do not even know they have PCOS. There are 30 to 70% of these women do have obesity as an issue. They have 50% of women have insulin resistant issues, and 50 to 70% of these women can have a condition called hirsutism, which is increased facial hair and hair growth.
Which can be tied to the increased testosterone, I'm imagining.
Correct.
How can PCOS affect one's health and one's body?
So it can actually affect you from head all the way down to your lower body. So if we start with the head, we have issues with anxiety, depression. We have actually linked PCOS in studies with mental illness. We also have dysfunction in the brain. There's a part of the pituitary, or one of the organs that's in the brain, where the hormone imbalance is off due to the ovarian imbalance. Then we move down to the face, and we'll see issues with increased hair growth. You'll even notice some masculine features in some of these women. Then with the skin, you can notice some dark patches on their bodies, and you'll notice some cystic acne, which could be very disturbing for our younger population and reproductive population. In the abdomen, you start to notice there's an issue with central obesity, and women have a bit of a tummy, and they think it's that they're putting on weight, not realizing it's part of their syndrome. And then down in the pelvis, due to the imbalance in the ovarian hormones, we have issues with the uterus. The lining of the uterus becomes very thick because the imbalance of estrogen and progesterone is off. The estrogen levels go up, the progesterone levels go down, and we wind up with a situation with the production inside of the lining gets very thick. Then with that, you have a woman who stops ovulating. And when she stops ovulating, she potentially stops menstruating or having periods. This is now when a woman gets very concerned and very worried about her reproductive health, and then she winds up with me.
We'll talk about that in greater detail in a moment. Is there a reason more common than the others that women would come to see you about this, or see another gynecologist about this?
Yeah, so it's become an amazing event. The American College of Gynecology has come up with a new vital sign. We actually look at the last menstrual period, or a lot of women know it as LMP. They come to the doctor to describe when their period was, how often is it, how regular is it, or are they having no periods at all? Now, an interesting thing we find is more and more young women are put on birth control. And they're either put on birth control for regulation of the cycle or simply prevention of pregnancy. So what happens is they get put on birth control, and what happens, they think they're having a normal menstrual cycle, but it's really the effects of the birth control. So as a patient told me the other day, Dr. Parise, I think it's a Band-Aid that I was put on birth control because I was having irregular cycles and my gynecologist put me on birth control. So now I'm having what looks like regular cycles, but really what's happening is she's having a withdrawal bleed every month. So she thinks she has normal periods, never realizing it's the birth control manufacturing normal periods. So she's coming to me in concern, is birth control okay and normal for me now to have a regular period, or maybe I'm not having periods on the birth control, or what's going to happen to me if I get off the birth control? So we spent a lot of time talking about periods, talking about what's normal, and talking about, is it okay to be on birth control when I'm having this type of irregular bleeding.
Are there necessarily downsides, and again we're going to talk about fertility later, but downsides to the irregular cycle versus a regular cycle?
So what an irregular cycle can demonstrate, if you're not having that normal release of the egg coming from the ovary, what's happening is the ovary is producing multiple cysts that don't actually release the egg and dissolve. So when you're not doing that normal ovulatory cycle, then you potentially will have issues getting pregnant, because if you can't release an egg, sperm can't come and meet that egg to actually get pregnant. So there can definitely be an issue with infertility, but like I tell my patients, there's always hope. They're always concerned, Dr. Parise, I'm not going to get pregnant. I'm so worried I'm not going to get pregnant. It's a very reversible condition. So there's a lot of hope out there. It just has to be evaluated and treated.
Do the ovaries look different in a PCOS patient? And if there is a difference, is that necessarily unhealthy?
So we say unhealthy, it's just the normal cycle for those ovaries are to have a balance of estrogens and progesterones that are healthy for reproductive women to ovulate and get pregnant. So when a polycystic ovarian syndrome patient is presenting, what's happening is she's not ovulating normally and monthly. So what happens are the ovaries can get enlarged. They can start to produce all these extra androgens or male hormones. And then what happens is when that reproductive woman wants to get pregnant, there's some trouble because there's dysfunction of ovulation when it's time to get pregnant.
If a woman never wants to get pregnant, do they look at this and say, this is perfect. I don't want to get, I never want to get pregnant, and I'd rather not be on birth control either.
And that's a perfect point, and I deal with that often. So if a woman is reproductive age and she chooses not to get pregnant or never wants to be in a situation where she can get pregnant, birth control can be a great option because estrogens and progesterones will be stabilized in the cycle. And what that does is help to balance the hormones of estrogens and progesterone. So she's not at risk of the situations that can manifest because of the polycystic ovarian syndrome picture, which is hypertension, high cholesterol, cardiovascular disease, diabetes, insulin resistance. So if she has no desire to get pregnant, she still wants to try to help treat the PCOS picture so she doesn't wind up with time have issues with any of the other metabolic conditions that can develop.
We were going to talk about infertility, but we've already done that, and fertility issues. So how is you said sometimes it is reversible and treatable. So how would that take place?
So there are multiple treatments we can use for polycystic ovarian syndrome. So depending on the patient, there's the patients who do want to get pregnant, and there are the patients who do not. So obviously a patient who's trying to get pregnant, you wouldn't recommend to put them on birth control. They want to conceive. So those particular patients, we're trying to supplement that lack of progesterone that's in their body. So what you would do is really have this patient do a nice journal of what their cycle looks like, what their symptoms look like. You're looking for mood disorders that go along with premenstrual mood symptoms. And then what we do is supplement progesterone later in the cycle. And in this way, we're helping to support the progesterone and the uterus for a potential pregnancy. So we would do progesterone support, and then what we would do is take medicines such as Clomid, letrozole. There's also gonadotropins and beta-HCG, which are a lot of big terms on helping that woman to stimulate the ovaries to ovulate. So we can correct the PCOS condition with lack of ovulation with multiple medications. If she's not trying to get pregnant, a way to stabilize that is birth control, daily hormones, estrogens, progesterones. You might want to treat that excessive androgen condition with medicines to suppress that hair growth. Those medicines are spironolactone, there's Vanaquat, which is a medication to try to topically try to prevent future hair growth. We also have medicines to treat the pre-diabetic condition, which is called metformin. Metformin is a great medication that helps insulin resistance, which can then also encourage ovulation. So the diabetic control actually promotes ovulation as well.
Let's talk about specific causes for infertility with PCOS patients.
So specific causes of infertility would be inability to ovulate. You're never going to release a mature egg if the ovarian hormones are not in balance. So that's definitely going to cause an issue with a woman getting pregnant. The insulin resistance is actually suppressing ovulation as well. And obesity is also another issue, which is going to go along with PCOS patients. And that also encourages a patient not to ovulate normally. When a woman is obese, there's extra estrogen in the body. Those estrogen and fat stores can set off the normal menstrual cycle and make it harder for that woman to get pregnant or even predict when they're ovulating.
Why is it that some women handle menstrual cycle better than others?
So why do they handle?
Yes, for some women it's the toughest time of the month. You referred to the moodiness, the things that come along with that. Mm-hmm. And then for other women it's nothing.
I guess it's like every patient. Everybody deals with pain differently. Everybody has a different threshold of pain and the mood symptoms that go along with it. When a woman is experiencing the drop in hormones in the body, which naturally happens, it can trigger anxiety, it can trigger depression. Some women have issues with the hot flashing and the irritability. So if a woman is more stabilized in her normal cycle and is monitoring it, she tends to deal with that and treat that much better than other women.
Very good. Why would PCOS lead to obesity? Because it doesn't, and it doesn't always, right?
Correct. So don't be fooled. There are PCOS patients that are not obese. So traditionally when we talk about PCOS, we think of overweight women. BMIs greater than 25 is indicative of being overweight.
Body mass index.
Yes,
right? Yeah.
correct. Body mass index. When a woman is over 30, then we're going along with obesity. PCOS tends to fall in that greater than 25 BMI. However, there are thin women who suffer with PCOS as well. So it doesn't always lead to obesity, but one major reason it does is because when a woman has that insensitivity, that issue with sensitivity to insulin when she has PCOS, though insulin cannot bring the glucose and the sugar into the cells the normal way somebody does when they don't have insulin resistance. So there's more circulating glucose in the body, and then with that, there's more glucose to store fat. So even if two people are eating the same, the level of glucose in a woman's body with PCOS is much higher, storing that as fat and then leading that to obesity. Then what happens, those obesity stores have more estrogen in them. That extra estrogen is also setting off that imbalance in the ovarian hormones as well. So you keep winding up with higher levels of estrogen, lower levels of progesterone, which then what happens is a woman is not likely to have that normal ovulatory cycle.
I'm going to guess that most people don't walk into your office and say, I think I've got PCOS, right? They're walking in saying, here are all my symptoms, and you're going, aha.
Right.
This is what. So how do you officially diagnose PCOS?
So what happens, a lot of these women come in, like we discussed earlier, is they're discussing their irregular cycles. They're discussing how they're not having that monthly cycle or sometimes not having the PMS symptoms that come along with it. And they're more curious if they're ovulating or is something wrong. So then you start doing a full overall history taking and an exam. These patients tend to express they're noticing increased hair growth, maybe even male balding in the front of their head. They may also talk about increase in acne. They also start discussing that they're really struggling with their anxiety and their depression. And then you start looking at body habitus. You start looking at potentially they're very frustrated that no matter what they do, how often they work out, that they tend to put on weight, where their friend who's eating much worse and not exercising near as much as they are, that they're getting...
It's not fair. Right.
It's not,
right.
I hear, it's not fair. What's wrong with me, Dr. Parise? So this picture of irregular cycles, increased androgen signs and symptoms, such as the increased hair growth, the acne. You'll even see some potentially male characteristics. That's going along with the PCOS picture. Then you might do an ultrasound because of her concerns and complaints. And it's quite often we'll see those typical ovaries with all those little cysts that go around the periphery of the ovary. And that helps us point to the diagnosis of PCOS.
And again, those could be the eggs that just didn't make it through.
Correct.
Right.
The sac is supposed to release and then dissolve, and what happens, it doesn't.
Let's delve a little deeper into the diet, recommended diet. If you're recommending a patient, look at the diet at PCOS.
So diet is really important. We want to cut back on the carbohydrates. So we don't want necessarily a full diabetic diet, but the PCOS diet is going to include low carbohydrates, full fat dairy, refined sugar-free foods, and then whole grains are definitely recommended. A lot of people are following the paleo diets, and everybody's cutting back on wheats and gluten-free, but the PCOS diet, you definitely can have that. It's just the biggest thing is cutting back on carbohydrates and eating more of your healthy fats. There are some great foods we like to recommend for the PCOS patient, and even great fertility foods. We have avocados. Salmon is also another great food we recommend for the PCOS patient. Being Italian, we all love our garlic and our tomatoes and tomato sauce. the beetroots, pumpkin seeds, bell peppers. You definitely want to have your non-inflammatory vegetables, which is going to help the overall condition as well.
And you mentioned exercise can be helpful. Any particular sorts of exercises? And obviously that's going to be better for you in the long run.
Exactly.
For, just total health.
Yes. So we definitely want to recommend those women to get off the couch. I think what a lot of us do, we work all day, we get home, we're tired. What do? We eat and then we lay down and watch TV. So the big thing is, I really recommend my patients after eating a meal, it's almost what does everybody do in Europe? You eat something and then you walk the neighborhoods, you get up, get out. 30 minutes of brisk exercise has been shown to help PCOS patients and even improve fertility. So brisk exercise, activity, and then the big thing is work on the stress levels. So many of our patients are stressed out, and that cortisol level is not good, not only for PCOS, but for hypertension, for cardiovascular disease. Overall wellness is really important all around.
And exercise and good dieting can help in those areas.
Exactly.
All right, you brought along a patient video to share with us.
Yes.
Tell us her story very quickly, and she's going to help tell us the rest.
So Barbara over here is a patient that I've known for some time. She's actually struggled with PCOS herself, even for when she was a child. We've discussed a lot about her PCOS and some of our upcoming future endeavors at Ochsner, and she wanted to share a story with us.
And let's let her do that. Here's Barbara.
I was a child when I was first diagnosed. Like normal kids, you expect to have like normal little girls, you expect to have your period, around 12, maybe 10 at the earliest. And then you expect that it's going to be every 28 days. Mine was more like every 40 or 50 days between periods. And I was gaining a whole lot of weight and having really a lot of anger issues and kind of being more like a boy. The thing with this particular disorder is that if you don't treat it, eventually it can lead to you having hypertension, diabetes, and all kinds of other issues that will cause your lifespan to be shorter as you get older. Back in the day, I used to go to a specialist who was a part of a different hospital system, and then I would see another specialist in a totally different hospital system, and they didn't talk to one another. Nowadays, I go to Ochsner and all my specialists are in one group, basically, and they talk to one another. It's key that they all know what's going on, and it's very helpful and nice that there is one medical record per the patient. So it's very helpful and nice to have that group mentality and that ability to be able to have several specialists talking together and working together on this one problem that really does require multiple specialists working on it. For right now, there's no getting over this. It's incurable, but if you treat it, you can live a better life and a healthier life, which is important.
And we thank Barbara for sharing her story. So talk to me about some of those other specialists who would be part of the team that Barbara referred to.
Yeah, so we're very excited. We're actually right here at Ochsner working on, at this very moment, a multidisciplinary team for PCOS. The area, Louisiana, actually does not have a multidisciplinary clinic, so this is what we have underway. There are multiple team members, and I have a colleague of mine, Dr. Susanna Dipp, who's an endocrinologist, and she and I have gotten together, very excited about wanting to create a place where a patient can come together and work with a set team, and actually a nurse navigator, and we'll see multiple physicians in this team. So it'll be myself, who's a general OBGYN, and then the endocrinologist is obviously taking care of the diabetic situation, any endocrine dysfunctions such as thyroid disease, prediabetes, diabetes, And then we're going to have a dermatologist who's going to be working hand in hand with us, who will be doing the cosmetic dermatology procedures, who will be doing the laser hair removal. We'll have an infertility specialist here in town that will be working with us on these patients. So then when the general medications that we use for infertility are not successful, they can then go and see the specialist to do more advanced reproductive technology. We will have a weight loss doc who's going to work on the weight loss regimen for the team, for the patient. And then we will also have the bariatric team who will also work with some of our overly obese patients to try to work on losing weight. This whole team will come together so that we can all discuss the patient's history, discuss the treatment plan, and make sure they're not feeling lost. Sometimes patients come in, a doctor recommends another specialist, they leave feeling, I don't know where to go from here. But our job is going to be to work in together so that patient's going to leave with set appointments, potentially with 5 different physicians, right when she leaves.
We're out of time, but I can sense the excitement in your voice as you're describing the group you'll be working with.
Yes.
Thank you very much. Dr. Angela Parise, OBGYN, for the education and information she has provided tonight and for your work in the Ochsner Health System. Thanks for being with us.
It was a pleasure. Thank you so much.
All right. Well, to make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen. It's set up just for viewers of this program. Or you can send us an email, and there's our email address, hellohealth@ochsner.org. As a reminder, you can re-watch this week's presentation or many of our other Hello Health programs on Ochsner's website. Ochsner.org is the address. Just type Hello Health in the search box. Our thanks again to this week's guests. Thanks to Humana and Ochsner for making our program possible. And a final thanks, as always, is to you for your support of this program, Hello Health. We'll see you next time.